Hi everybody and welcome to this special video from A Spoonful of Oral Medicine. I am very excited today to be able to speak to Professor Daniele Manfredini. If anybody here is interested in bruxism and has looked at the literature on bruxism, you would know that Professor Manfredini is a world-renowned expert. So I would really like to thank him for taking the time to be here with us to answer commonly asked questions about bruxism.
Thank you for this very nice invitation and good afternoon to all my Australian friends. It's morning, early morning actually here in Italy. So I just drinking a coffee cup to be ready for this conversation.
Okay, so let me start some screen sharing because I've put some of the questions on a PowerPoint slide. So for people that may not be aware what this series is like, I go through Google and I look for the most commonly asked questions and we go through them and have a little bit of a discussion together.
Of course.
Thank you. So Professor Manfredini is in Italy. He has more than 180 papers in the field of bruxism and TND. He has edited or co-edited multiple textbooks and book chapters, and there are not many people in the world who know more about bruxism or are more of an expert. He also, and this is the bit that I really admire about you, Professor Manfredini, is that you're so passionate about educating. You've got a Facebook page, you've got a study club, you've got a website, you run a TMD camp. So what led to your passion of sharing your knowledge about bruxism and TMD so widely?
Well, Amanda, I guess that like in many other parts of the world, we experts in the field of temporomandibular disorders and orofacial pain see a lot of patients who are overtreated concerning all that factors and issues related with dental occlusion. So I guess that we have the social duty to diffuse the important information, let me say, to save many patients from overtreatment. That's what makes the difference between teaching and just lecturing for ourselves. So that's why we created a study group on Facebook. We have a lot of events. By the way, on June the 6th and 7th, there will be a very big online event. Our international congress this year will be forcefully organized online. I invite you to browse the Facebook page of the study group to find the way to connect with us and to stay updated with all the latest news.
Great. All right, so let's look at some of the most commonly asked questions about bruxism.
Move on.
So what is bruxism?
Well, what is bruxism? As you know, just a couple of years ago, we prepared a consensus paper that redefined bruxism. Exactly, this is the paper. And we opted to include under the umbrella term bruxism all the different activities of the jaw muscles. So bruxism is not only the act of grinding the teeth during sleep, but it is also a clenching and a bracing activity of the jaw muscles that, of course, may be performed during sleep, but also as an analog during wakefulness. So bruxism is not related with the act of grinding the teeth, but it is a much more comprehensive term nowadays.
Great. And I noticed that this paper says that it is a work in progress. So is there a part 2 coming?
Not necessarily a part 2. This is actually the part 2 of the consensus paper, the original consensus paper we wrote in 2013.
Yes.
The work in progress is related with the need to define the best way to assess bruxism, to understand the etiology, and to manage bruxism. Nowadays, we consider bruxism just as a sign of something. So we are preparing an evaluation system that we have called STAB, Standardized Tool for the Assessment of Bruxism. If you browse the Medline, yes. It just appeared some weeks ago. And in that system, we went through the assessment of the etiology, the status, and the possible consequences of bruxism. So that's why we called this paper work in progress.
Yes. Thank you.
Welcome.
So the next question is, and this is, I suppose, from a patient, how do I know if I have bruxism?
Well, in many cases, patients still associate bruxism with the fact that they have to grind the teeth during sleep. So they often answer or say, my wife or my husband says that I'm grinding the teeth during night. Actually, of course, wearing the teeth is a possible sign of bruxism, but it is also sensate to understand that the clenching type and the bracing type of bruxism is more related with the possible presence of fatigue in the jaw muscles, even pain in the jaw muscles, signs at the intraoral level like lingual scalloping or linea alba in the cheek mucosa and stuff like that.
So is pain necessarily a symptom?
Actually, it isn't. And one of the most important challenges for the future will be to discriminate between the bruxism activities that are related with the tooth wear and the bruxism activities that may be related with muscle fatigue and pain. And if the world were black and white, we could classify teeth grinding as a source of tooth wear and jaw bracing and teeth clenching as a source of muscular fatigue and pain. But of course, in the clinical life, it is not black and white. So many patients have a combination of activities. And for us as clinical researchers, the goal for the future will be to measure the amount of muscular activity to try to understand if it is possible to correlate it with the clinical consequences.
So I don't do this myself, but I know there are some clinicians out there that have picked a arbitrary number, so say maybe a few millimeters, and they actually try to measure the amount of masseter hypertrophy. So if they say that if it's above, if you have the masseter that's bigger than a centimeter, does that actually correlate with anything?
Actually, it isn't. Of course, it could be a strategy, but we don't have standardized data for normality. So it could be a sign or let me say, just a clinical record that may be useful within the whole data we can collect, but it is not possible to create cut-off data to discriminate between the bruxers and non-bruxers.
Thank you.
Welcome.
So this is a big question. What causes bruxism?
Okay, question of the day. As a combination of possibly different activities, bruxism, of course, may be caused by different conditions. So the real goal for the clinician is to try to understand the condition that is mirrored by bruxism. So in general terms, of course, uh, I may suppose that clenching type of bruxism, so tonic contractions may be related with psychological issues, so stress sensitivity, anxious personalities, and that kind of stuff. But on more general terms, there are other issues concerning the sleep architecture that are emerging as really complex to study. So now we know that bruxism may be related with, of course, neurovegetative arousals, respiratory arousals, the intake of drugs or substances, of course, neurological issues, comorbid conditions, gastroesophageal reflux disease. So a lot of issues that we are trying to put into the etiological part of the step.
One of the really nice papers that I think you've shared is that there is a lot of literature out there on bruxism and I suppose TMD, and I think, did you call it death by literature, or death, like where the meta-analyses and the systematic reviews, there was just too much and a lot of people were misunderstanding the relationship between association and causation. Now, do you have any comment on that? Because sometimes when someone reads a paper and an association is found, they end up over treating the patient thinking that the association is causation.
Yes, of course, that may be a problem. I don't think that it is necessarily related with an interpretation of causes and effects in terms of the Bruxism literature, okay? But in absolute terms, it may be a problem. But I think that the real big problem is the abuse of meta-analysis. I'm not a particular fan of meta-analysis. I hate network meta-analysis because to me they're an absolute nonsense. Just because you cannot guarantee the homogeneity of samples in different studies, and especially in pain medicine, there are factors such as, for example, the psychological issues of the patients that are really critical for the outcome of the treatment, and the patient to doctor relationship is another one. So it is really not sensate to perform artificial meta-analysis. Sometimes I feel that they are just an attempt to write another paper and to involve young researchers to do something, because don't forget that it is really much more easier to perform a meta-analysis and to write a literature review than to perform an original study.
Yes,
okay?
True. So can bruxism go away by itself?
Of course, everything may happen, but the real missing link here to answer to this nice question is that actually we should know something about the causes of bruxism. So, for instance, if a patient drinks 12 Italian coffees per day, and then he stops. Of course, bruxism can go away. Same is for drugs, same is for psychological situations, same is for treating sleep disturbances, for instance. So to really answer properly this question, we must understand that bruxism is just a sign of something. I love to compare it to fever or to body temperature, okay? So it can go away, but we have to understand the causes.
Is Italian coffee a lot better than Australian coffee?
Of course, of course. We have many better things than other populations, okay? We are not really able to sell them.
Soon, hopefully. All right, so this is another big question. How do you treat bruxism, and does it always need to be treated?
Yeah, of course, as you know, this question is strictly related with the preceding one, because to really treat bruxism, you should understand the causes.
Yes.
If treatment is intended as a causal therapy, of course, you can manage the consequences, manage tooth wear via dental restorations, or manage temporomandibular pain via oral appliances, physiotherapy, or whatever you want. But to really make a patient stop bruxing, which is the core meaning of the word treatment, you have to understand the causes.
What happens if someone doesn't, what happens if a patient has bruxism and they decide not to get it treated? So the obvious answer here is that the underlying cause, if there's any, will not be detected and treated. But what is some of the end stage consequences of untreated bruxism in itself?
It depends on the severity of the activity. From my experience, the real issue may be the undiscovered presence of some severe health conditions that are mirrored by tooth wear, for instance. We can see that many patients with tooth wear now have sleep apnea, and sleep apnea may be a real health concern, okay? A life-threatening, potentially life-threatening condition. So if you don't treat that and just look at the patient and say, okay, you have tooth wear, you may end up with a bigger problem than tooth wear. But concerning the other side of the coin, the relationship or possible relationship between bracing and clenching type of bruxing and pain, of course, patients require treatment because pain is one of the main reasons for patients to seek an advice.
So just to be clear to our listeners, if you have a patient that has bruxism, simply giving them an occlusal splint to stop tooth wear is not adequate. Is that correct?
I'm not a particular fan of doing or acting like that, because I love to get deeper. So the first step to do is to try to measure bruxism. So you have to buy or to use, of course, at least electromyographic recordings for the night, or polysonography recording for the night, better, and to monitor the activity during the day. Nowadays, we have, for instance, these smartphone applications to monitor the real-time activity reported by the patient. But just putting an appliance into a patient's mouth is like an ostrich putting the head under the sand. So I don't like this kind of attitude.
Okay. All right. So now we have some frequently asked questions from dentists.
Okay.
Can you reliably distinguish between a bruxer and a clencher with the clinical examination?
I will reformulate this question and say, can you distinguish between a grinder or a grinding type of bruxer and a clencher? Of course, in general terms, you can do it, but it is not necessarily easy to do that. I will stress that patients with tooth wear rarely have pain in the jaw muscles and the temporomandibular joint. We all know the weak link theory and some past approaches telling us that there is a sort of weak link in the stomatognathia system, so it is either the tooth or the TMJ and the muscles that is let me say, injured by bruxism. Nowadays, we may hypothesize that it is the type of bruxism activity that is related with the consequences. So basically, when you have a patient with tooth wear, you may hypothesize that he or she is a grinder. When you have a patient with pain in the jaw muscles and temporomandibular joint, from my experience, she or he is rarely a tooth grinder, but they are always persons with clench and bracing type of bruxism. I love to say that they are biting their lives.
Now, another one, best splint type for bruxism. These are questions that I get asked pretty frequently.
Yeah, and this is the typical questions by dentists. And I'm used to say to during my courses that this is the type of questions that I would expect from my lab technicians, not from a doctor. Because if you understand the reasons for a patient to have pain, the mechanism of effectiveness of oral appliances, and by the way, we will talk, I will personally talk about this topic during our Congress, because I will give a lecture on the effectiveness of oral appliances for temporomandibular disorders. So if you understand why appliances are effective and which is their possible role, there's no way to debate about which is the best splint. So it's not a problem of canine guidance or centrivillation or that kind of stuff. Of course, in the case of bruxism, sometimes you may be happy with the effectiveness of advancement devices just because you solve the apnea issues, okay? But unless you go deeper into the analysis of the causes, it is a nonsense to speak about who is the best splint type for bruxism. If you want to interrupt bruxism, otherwise you can just manage the consequences.
Yes. Thank you for that. That's a really good answer.
I know.
All right. So this is the one. There is the literature, I think, is very clear on this, but this is something that I myself come up against time and time again, where dentists are doing occlusal adjustments, occlusal equilibration for bruxism, for treatment of bruxism and TMD. Are you able to comment on that?
Of course I'm able, and the answer is really clear cut this time. There's absolute no way to touch a patient's teeth. There's no need to do that. Occlusal equilibration or occlusal treatments in terms of irreversible changes of dental occlusion are not needed to treat bruxism or to manage temporomandibular disorders, period.
There you go. You heard it from Prof. Manfredini. Don't do it anymore. And I think I've just got one last question. This is another one that I get asked often. And I think it's because people are using this for an occlusal adjustment. So they ask me when they should be using a leaf gauge. So a leaf gauge is something that has several layers in it where they use to, is there ever a time that we need to use it for treatment of bruxism and TMD?
For treatment of bruxism and TMD, that's a very weird question because actually I don't see any real connections. Of course, leaf gauges may be useful if you want to, let me say, test the thickness of all your appliances, but there's no ideal thickness. So to me, it is an absolute nonsense. It is a technical artifice, but I always invite people who have dogmas concerning these issues, or even facebos, for instance, to test their hypothesis against an alternative explanation. So use less leaf gauges and see what happens with your patient, or don't use them and see what happens with your patients. Absolutely no difference.
Great, thank you.
You're welcome.
So thank you so much for joining us, and thank you for such a great presentation. I think we made a lot of really good points here. I've put some of the links from my thing, which is a spoonful of oral medicine, and I've included some of the links to your Facebook group, and I think this will also, I'll send it to you and you can distribute it as you see fit as well. Before we go, have you got any other final comments for any dentists or dental students or patients who may be watching?
Thanks for this question. Of course, for the compliments. Honestly, I think that this brief talk has covered all the main topics concerning bruxism and temporomandibular disorders. And the main final message is that you have to study and you have to go to the proper sources of information, because I see, at least in Italy, but I guess, and in Europe, but I guess you have the same problem all over the world. Sometimes there is a tendency to go listening to experts or purported experts talking about temporomandibular joint disorders and bruxism, who actually don't even have a certified title to speak about the topic. So in Italy, for instance, we have a lot of orthodontics or orthodontic congresses, so with an audience of orthodontics, inviting an orthodontist to speak about temporomandibular disorders. That's not the right way. So I always invite students to search for the information coming from the academies. Of course, you have the very nice Australian and New Zealand Academy. I was invited last year, as you know, to be a speaker at your wonderful meeting in Sydney. And we got the American Academy, the European Academy, the Asian Academy, the South American Academy, and the national representatives and alliances. So you have to get there to find the proper information, because there is a lot of misconception. There is a lot of money surrounding the topics of temporomandibular disorders and body posture. And so actually, I think that we have the social duty to as teachers, to diffuse and to steer our students toward the best way to find the proper information. My final message for you is, of course, an invitation to join us on Facebook and to attend our live event, our Congress on June the 6th and 7th. The topic will be the clinical management of temporomandibular disorders. The Congress will be almost entirely in English. My friend Rob Del Cano, and by the way, in Perth you also have Senji Kandasamy. Hi, Senji, a very nice friend of me. Two wonderful examples of evidence-based approach to the temporomandibular joint patients, temporomandibular disorder patients in Australia. And I was saying that the topic will be the clinical management of temporomandibular disorders, and it will be like a book chapter, a sequence of book chapters from the etiology, the diagnosis, to the management of complex cases. There will be a lot of interaction, so I hope that many Australian and Pacific Islands friends will be there with us. As for me, I thank you. I really enjoyed this time, and I look forward to the registration, because it is always nice to go live and see what happens when you see the recordings. Okay, bye-bye.
Thank you so
Thanks.
much. Thank you. See you.
See you.